All right, we'll get started. So, hi everyone. I'm Angela DiDonato. I'm sorry to disappoint you and not be Marion, but she was a little double booked today. We all know how busy she is. So I'm here to introduce Danielle Alteris Sarek. She's the Director of Nursing Research and Evidence-Based Practice at Nicholas Hospital and the Senior Policy Service Professor at George Washington University and a Senior Fellow at the Center for Health Outcomes and Policy Research at the University of Pennsylvania. So she is a pediatric nurse scientist and health services researcher. She focuses on improving systems of care and outcomes through policy, innovation, and research. And Dr. Sarek earned her PhD, MSN, and BSN, all from the University of Pennsylvania, and a BA from Cornell. So we are excited to have her. Thanks so much for doing this, Danielle. Welcome.
Thank you so much. I can see that we have a couple of folks on, so I would love to. I know I don't think people can speak, but I would love to just know. I'm not sure if you can raise your hands about like, are you undergrad? Are you graduate? Are you faculty? Just kind of to get a sense of who I'm speaking with today. So I don't know if you're able to put any messages in the chat, and Angela, if you're able to share any of that with me. It just helps me to be able to, make sure I'm telling you guys things that are important and align with your interests. Are you seeing anything come through?
No.
No?
Mm-mm.
Okay. Well, I'm going to assume that you guys are all currently at Penn, and that you are likely in a student role there. So please feel free to let me know if that isn't true, but I'm going to kind of share some information today that hopefully will be helpful to you. So thank you for introducing me. I'm Dr. Danielle Sarek. I'm going to tell you a little bit more about myself and my journey. So we're going to skip over this first slide here. I do have several different research funding sources. So I just want to acknowledge those and make sure that, there's no conflict of interest there. And then, today we're going to have, 45 or 50 minutes together. And this is just kind of an overview of what I'm hoping to speak about. It sounds like this is going to be, kind of an opportunity for a little bit of a less formal talk just about what does it look like to take your nursing skills, combine that with research skills, and then really work to improve issues that we see at the bedside. So I'm going to start by just talking a little bit about myself, my own journey, just to let you know kind of what that looks like. We're going to talk a little bit about a clinically based nurse scientist role. What is that? What do individuals in that role do? And then an overview of transition of care, where a lot of my research work and clinical work has been. And I'm going to highlight two programs today. So one's called Baby Steps, and the other is Innovating for Impact. And then hopefully we'll have some time at the end, and we'll wrap up just with a couple of insights and perspectives, just some food for thought that hopefully you can take with you. So I really like starting with this quote, which is from a 2001 Institute of Medicine report, because I think for me, when I reflect on why I entered the field of nursing, why I continue to go back to, get my master's and my PhD and what I do on a daily basis, I think this quote really reflects that thought process that drives me. And I think for most of us in nursing, we started in this career because we wanted to make a difference. And unfortunately, what sometimes happens is we make it to the bedside, we're in clinical care, and we start to see all the places where we have gaps, we have challenges, where we learn the best practice and it is not the best practice that's happening. And that can be really disheartening, right? That can be really frustrating. Alternatively, we can use that as fuel, right? And we can use that to really see, okay, where can I, as a nurse, as a scientist, as an innovator, where can I help to bridge that gap? Where can I make sure that I'm addressing that challenge and I'm moving care forward? So because we all come to all of our different aspects of work with many different parts of ourselves, this is just a slide to kind of highlight that. So being, for me, being an innovator, clearly there are the clinical pieces, there's the research piece, but then there are all of those other unique experiences that we carry with us that change the way we think, change our lens, change even what we think is the most important thing to focus on. And that is incredibly important. I think we do ourselves and we do our patients a disservice if we are only focused on kind of this one single aspect of ourselves. I think it is really important we bring our whole selves to the challenges that we're facing. So a little bit about my kind of unique path, my trajectory to get to where I am today. And you'll see here some of those pieces of like that unique perspective that might come up later. So I went to Cornell for my undergrad. I was a major in biology and society. I minored in global health, and my first career was actually in global health. So I didn't have nurses in my family. I didn't really know about nursing. We didn't have a nursing program at Cornell. And so it wasn't until I was in that global health environment that I first worked with a nurse. And it was a master's prepared nurse. She was a nurse midwife who also had advanced training in how to run programs and programmatic analysis. And I saw that work that she did to build, implement, and then evaluate programs in developing countries. And I loved that work. I thought it was so interesting. So I decided to go back to school. As you guys heard, I'm a three-time Penn grad. So I did my second degree BSN. I stayed on for the master's. I'm a pediatric nurse practitioner. I've practiced the majority of my clinical life in primary care, pediatric primary care. You can see some of the locations here on the slide. And then I was hoping to go and get a master's in public health. And I was in the Center for Health Outcomes and Policy Research at Penn, working as an RA. And Dr. Aiken told me, why would you get an MPH when you can get a PhD? And I said, well, that sounds interesting. So then I came back for the PhD. Because I had that background in global health, I worked in policy and advocacy. And so through my time at Penn, I was really interested in looking at systems of care and how do we think about improving care at the system level, innovating at that, that above that patient level, at that higher level to improve our outcomes for our patients. And so when I finished up my PhD, there was an opportunity for me to join Nemours Children's Hospital as director of nursing research. And so I jumped from academia into the clinical setting. And that's where I've been ever since, is in that clinical world. So I started at Nemours. I then transferred to a Nicholas Children's Hospital, which I'll talk a little bit more about. I've also spent time at ChristianaCare as a nurse scientist. And I currently have a appointment at GW School of Nursing. And I also am a senior fellow or a fellow at UC Davis, Betty Irene Fellowship for Nurse Leaders and Innovators. So I get to wear a lot of different hats in my role. I get to kind of pull in these different pieces of myself, these different, experiences and understandings I have from my journey. And to me, that has been instrumental in helping me to think innovatively about the challenges that we face. So as I stated, I'm at Nicholas Children's Hospital now. That's located in Miami, Florida. So I direct nursing research and evidence-based practice for the organization. We're now at 325 beds. We are adding 2 additional hospitals within the next few months. So taking over their pediatric functions in those hospitals. And so our setting cares for children from across Florida, South Florida in particular, Central and South America as well. So we have a large international population. We have a very diverse patient population. About 70% of our patients speak Spanish, and about 70% of our patients access care using public health insurance or Medicaid. And that comes into play because, as you see later, we have some challenges with the way that our families are able to access or understand the care that they're receiving. So in Nicholas, I work as the Director of Nursing Research and Evidence-Based Practice, otherwise known as a clinically based nurse scientist. So this is a role that has really kind of gained traction and grown a lot in recent years. And, even within the last few months, there have been a few national articles about what is a nurse scientist? What's the value of a nurse scientist? What can a nurse scientist bring to your healthcare organization? And I think a lot of this is driven by our magnet designation and magnet standards. So, as you may know, hospitals that want to become a magnet designated organization need to demonstrate a portfolio of research and evidence based practice. And so, in order to do that, they often need someone like me who understands the clinical world, but also has that research training to help identify and lead research, EBP, and QI in the clinical world. So what does the role really do? A big part of the role for most people is really allowing that doctorally prepared nurse to translate evidence into practice and then also to guide new evidence creation. And really at the core, it's about addressing challenges, closing the gaps. And the really unique thing, the thing that I love, is that you are close to the issue so you can be close to the solution. So today, maybe a nurse comes to me and they say, we've noticed that we have a lot of challenges with getting our patients, our younger patients, to take their medication. It's causing length of stay issues. It's making it so they have to delay discharge, or if they go home, they have to go home with lines that puts them at risk of, other negative outcomes. So we want to address this. We want to think about an innovative solution. How are we going to educate or prepare these patients in order to, address this issue? So the problem could come to me today. I could meet with that group of interprofessionals, today, tomorrow. We could come up with a plan, help put together an IRB, a protocol, and within a month or so, we could have, a small project that we are evaluating the outcomes of an intervention. So really it helps to eliminate some of that bureaucratic red tape that sometimes can occur when you're trying to work on an issue, but you're geographically removed from the issue itself. So I'm going to spend a little bit of time now transitioning into talking about an area that I've spent a lot of time looking at, which is transitions of care, specifically in the pediatric world, because that's my background. And really just kind of thinking about, what does this look like? Again, like I said, I'm going to focus on pediatrics, but if you're an adult person, or really if you're focused anywhere in our healthcare system, these are kind of evergreen issues. So you can definitely take some information from this. So, to start, I would just say, imagine what an ideal transition might look like. And for the exercise of today, let's just think about what would it look like for a patient and a family who is receiving acute care in an inpatient setting, and they are getting ready to go home, and they're getting ready to transition back to the community and hopefully back to their normal rhythms of life. So when we think about that ideal transition, we think about maybe that they have really clear instructions, that they understand what care they may need after they leave the hospital, what follow-ups they may need. Ideally, we would want a lot of that anticipatory guidance or support to be given in the language that makes sense to that patient or family. We'd want to know whether or not that patient and family can read, or do they need to have that information given to them verbally or in other methods. We would hope that when they go back into their community, they're able to access the care. They don't have to drive hours and hours to go to their follow-up clinic, or they don't have to wait 6 months to get in to see a specialist. And then we hope that if and when they are able to get in, they can pay for that care. There's not a financial burden. They can go and get their medication from the pharmacy. And if they have an issue, say they have a question, a concern, something doesn't seem right, we would hope that they have some communication seamlessly and some support either from their community providers or even maybe back to those providers who cared for them in the hospital, right? Because they know what that transition was supposed to look like, what they were hoping for. That's kind of ideal. So, just reiterating some of these things, we want our ideal transitions to be human-centered. And that would mean both before patients go home and then after they go home. We want access, we want clear understanding. As I said, the financial resources that patients need to access the care that they require. We want community resources. That's something I didn't really touch on, but we want those to be explained and available to our patients. And then again, that last one, that seamless information transfer, that can be really key. I will say that, working in the primary care setting for many years, unfortunately, I didn't often see this, right? This was not the norm, I would say, for the way that patients and families would come to me after discharge from acute care. And I think now that I sit on the acute care side, what I see is all of the work and all of the effort that we put in to make sure that these transitions go well and make sure that our patients are prepared. And somehow we still have that gap often. So what is the reality then? You can see on the screen, these are the things that we're dealing with. When we look at transitions, when we're thinking about, how do we improve these transitions for our patients and our families? These are the realities that we are up against. We unfortunately see that a lot of these things are exacerbated by social determinants of health or adverse social determinants of health. And so in that way, these things often are kind of dovetailing together. So when I think about innovating and when I think about, how are we really going to make it so that this process is an improved process for our patients and families, these are the realities that I want to address with the work that I'm doing. So this is just another way of outlining it, kind of another overview of what some of those challenges might be. So again, when I engage in the innovative process to kind of think about those clinical innovations, addressing those gaps, thinking about things differently, these are some of the key things that I am trying to cue in on as a researcher, as a clinician, as a parent, as someone who's used healthcare. So health literacy and language, you'll see this as a major component of some of the innovative work that I've done. Mental and emotional health. This is something that's kind of, maybe ancillary to the clinical care that we often provide, but impacts all of the outcomes for our patients. And when we think about that dyad of patient, a child and a parent, the mental health of that parent, which is often the mother, especially in cases of like the NICU and things like that, that is incredibly important. And if we're not thinking about that during transitions, we're really missing an important piece of the puzzle. Financial challenges, we could develop the most innovative, best, whatever. But if there's a financial barrier to using that, we either won't use that intervention or it will be used, there will be disparities in its use. So certain folks will have access to it and their care will improve and others won't. Access, we know that even when we're in an urban area, we can have challenges with access. We could have transportation challenges. We could have parents or patients who are unable to take time away from their jobs or family responsibilities to be able to make it to appointments. And so this is something that I try to think about and I try to address when I'm innovating as well. And then siloed care and information sharing. I don't think there's one of us who has not experienced this, if not only in our own clinical care, but in providing care for others. We have so much information, but it lives in silos. And to get those different systems to talk to each other is incredibly challenging. So, all right, so take a step back. I've just kind of laid out all of the bad things, right? I've laid out all of the challenges. And then what does that look like? When these non-ideal transitions occur, these challenges occur, What are the impacts that we see? So unfortunately, often what it looks like is a readmission to the acute care setting. We know that this is common. So if, for example, in our NICU babies, about 10% of them will be readmitted within 30 days. And especially for some of our patients with chronic or complicated health conditions like epilepsy, they will unfortunately see many readmissions, and that can be very detrimental. There's an economic and an emotional burden of these, non ideal transitions. We can have a huge impact, a negative impact on our family and patient experience as well. Think of how frustrating it would be. You're trying to navigate, you're trying to get the best care for yourself, your family, your child, and you keep hitting these roadblocks. And then on the clinical side, we know that planning for discharge and trying to get people where they need to be, it's time and labor intensive. So if we're putting in all of this effort and we're not getting the outcome we want, we need to think differently about how we approach the problem. So one of the things, so one of the innovation or innovative models that we have developed in order to address this issue of transition of care is something called baby steps. And I'm going to give you an overview of baby steps and just kind of show you how this work was informed from patient voices, from nurse voices, and then how from that research perspective, we were able to pull it all together. So, first, just to lay the groundwork, about 1 in every 10 infants born in the US will be readmitted or will be admitted to the NICU after they're born. And for those babies, they're going to be at about 7 times the risk of readmission to the hospital than their full-term peers. So not only do we see system level disparities reflected in who's admitted to the NICU, we then, after discharge from the NICU, see the impact of those adverse social determinants of health and those disparities in who comes back to the NICU, or who goes to the ER, or who goes to the urgent care center. So there's a huge equity issue here. And it's also arguably, if 10% of babies are experiencing the NICU, there's a huge opportunity to make an impact on patient outcomes. So I'm going to just play this video for you if I can. So please let me know if you can hear it once I hit play.
The Baby Steps program is very important because it addresses that period of time after discharge, which is a very acute period, 1 to 2 weeks, where families are leaving the hospital with their new NICU graduate, they're transitioning home to the community, and they have to reestablish all of their routines. They need to learn how to care for their new baby. They need to make connections with their community providers, and they need to establish their own rhythm in their home. Infants seen through our program have many needs, healthcare needs, and the families can be overwhelmed with meeting those needs at home. To have the support of a nurse in the home environment is just a wonderful support to the families and much needed. One of the things that's really unique about it is that it was nurse developed and it's nurse led. And so because of that, we have this very holistic approach where we have the clinical component, but then we also provide holistic support for care management, for mental health, for food insecurity, and for some of those social determinants of health that we know are so important for positive patient outcomes. We meet the parents at the bedside. We go into the patient's room. We introduce the service of baby steps, which we give them the transition of care for up to 2 weeks after they get discharged. We give them our information. We give them a brochure in which it gives details of the services that we provide. We also provide the services in both English and Spanish. And we pretty much explain to them that this will be a virtual visit after they go home. We like to set up the appointment 48 hours after their discharge, which is usually aligned with the time that the pediatrician's appointment is. Every parent goes to the pediatrician's appointment. They have a lot of questions and a lot of times they forget it.
So we want to address all those questions after they get home from the pediatrician. We'd like to do most of our calls through video so that we can address any safety issues, any needs or concerns that the parents may have with equipment that they might have. Also, if there's anything on the baby, like such as skin issues, or if they have any questions with their formula, they should be able to show us through the video. Program provides support to all families. So all children that are seen through our neonatal intensive care unit are provided the option to enroll.
We're making sure that our patients, 70% of whom say Spanish is a primary language in the home, and 70% of whom use public health insurance to access care, have the ability to use baby steps.
For children enrolled in our program, we've seen about 54% reduction in families that are readmitted to our neonatal intensive care unit, which is a tremendous value to the families. We've also seen a decrease in families returning to an emergency room or an urgent care center following discharge.
I was scared. Johnny is my first child, and he was born at 23 weeks. And the journey has been like a rocky road, and it was like great to go through the journey. So when I got home with Johnny, it was stuff that I still was like unsure of doing, being home with him by myself, like not having a nurse by my side. And with baby steps was that nurse for me.
He actually went home after 9 months of being in the NICU, and he went home with a lot of active diagnoses. He also went home with oxygen and a feeding tube, and I was able to help the mom and transition her with some technical issues she had with the equipment, with helping her with her community resources and her community providers. It was really important that we were actually able to connect with her, have virtual calls, video calls, and she felt very happy and satisfied with the end of the program, and still to this day has told me that Johnny is doing great. He's walking and he's eating baby food, and we're just very happy and glad that this program was able to service him.
Yes, I would recommend baby steps to new parents because it's very helpful. Baby steps has the answers when you're unsure, and it's right at the touch of your fingertips.
The primary driver behind us being able to start the Baby Steps program was funding that we received through the Florida Blue Foundation.
Oh, sorry, I didn't mean to stop sharing. I just meant to stop the video. So let me bring that up again. So, I think I like to play.
We were able to receive three.
I like to play that video just because I think hearing from a mom in her own words about kind of what the impact was and what that feeling was when going home with a NICU baby, I do think that is really helpful. So, and speaking of, this is my little baby who's now 8 years old here. She was not NICU, but easier to use her picture because didn't have to go through all of the HIPAA hoops. Anyway, so what is Baby Steps? I think you probably got the kind of the overview of it from that video, but at its core, Baby Steps is a nurse-led telehealth intervention to help bridge that gap that occurs after discharge from the NICU during that acute first few weeks at home. And this really came out of feedback that we were getting from our NICU families. We were seeing a lot of readmissions of our NICU babies coming back, and we were seeing a lot of ED and UCC use for our NICU babies and families. And clinically, we were thinking, like, why is this happening? They've been with us sometimes for 2, 3, 4, 5, 6 months, maybe longer. We are a level 4 NICU. We're a non-birth hospital. So all of the babies who come to us are fairly complex. So some of them spend a very long time with us. So we were thinking, you've been here forever. We've taught you, we've, giving you the materials. Why is this happening? And so, I brought my perspective from the primary care world. So, because I would take care of these NICU babies. clinically when they were discharged from the NICU. I would hear the needs of the families. I would see those confused discharge kind of paperwork issues, the lack of information coming because of the silos. So I kind of took that clinical experience. I combined it with my research expertise on health outcomes research and transition of care research. And then I partnered with our clinical experts on the inpatient side, our NICU experts, and our families who were telling us, yes, like we get all of this teaching, but when you go home, it feels different. We had our nurses around us for 24 hours a day, and now it's not even necessarily like, anything big, but it's that uncertainty of how do I care for my baby, some of the basic things even in those first couple of weeks. So we developed this program to provide transition of care support through a telehealth or a virtual platform for up to 2 weeks after discharge. As you heard in the video, it's a nurse-led intervention. We talk about typical anticipatory guidance things, new baby things. So feeding, eating, sleeping, safety, things that we would do with other babies. But because NICU babies have all of these other complexities, especially the babies we cared for, we realized that some of those things maybe weren't as emphasized. And when parents went home, that was what they had questions about. We also connect with community resources. We provide support if there is a social work need or a mental health need. And importantly, I think we provide this care free of charge to the families. And if a family doesn't have a smart device like a tablet or a phone to access the care, when we started the program, we had available devices that they could take home with them. Interestingly, what we found was none of the families actually took us up on that. So we still have them available, but they're really not used. But what we were hoping to do with that is we were hoping to decrease that barrier to accessing and using the program. We also make sure we're addressing that language piece, right? Because we have the bilingual nurse and we have the ability to use real-time interpreter services, which is an application that actually participates, the individual participates in the Zoom call. So it happens in real time if there's a language other than English and Spanish. So you can just see this is what, our brochures look like. We already kind of talked about, parts of this, but I think one of the things that makes it really unique is that nurse-led piece. And I think, we have some other programs at our organization. Some of our residents will do follow-up calls, but that's really, they bill for those calls and that's more medical focused. Sometimes we have some follow-up calls that are specifically looking at, did the family, were they able to connect and get their medical equipment once they went home? But this is really that holistic approach that is saying, we see you as a parent. We see you as a whole person. And we realize that, yes, well, we've maybe taught you how to care for the G-tube or the oxygen. You may still have the need for some transition of care support. And we're here for you. So we have one visit that's set up 48 to 72 hours after discharge. And then for that 2 weeks, the parent can have on-demand or scheduled visits as many times as they would like during the 2-week time period. So in the first 5 years, we're now up to 5 years, we've enrolled over 800 infants and families, very high satisfaction. We've done some analysis to look at who's actually using the service. And when we looked at the Florida Department of Health, health shortage areas, kind of the areas that have those indicators for having barriers to access care, we saw that we had high uptake of this program there. So that was really a goal of ours. So we were happy to see that. And then, of course, the clinical outcomes. This is why we started the program. And so we were able to measure readmissions and ED and UCC use and see that they significantly decreased as well. This is just some demographic information, just showing that we had a very diverse patient population. As you can see, we had about 55% public health insurance and then about 8% both. So that kind of, aligns with our 70% overall that use public health insurance. We've done a lot of different work with this. I'm not going to go over it in detail, but we did use some GIS mapping to look at where we had uptake of the program. And what we were able to see is that we had, widespread uptake, but specifically in areas of the greatest need, which is what we were really interested in. And again, these are just some of our metrics. We did also look at the some metrics for the parent and the family impact. So we looked at travel. If you've ever been to Miami, you know that the traffic is horrible. And if you've ever had a young baby, you know, sometimes putting them in a car, especially if they have, you know, maybe some respiratory issue or a chronic health issue, you want to avoid that if possible. And so we looked at averted travel. We were able to put some dollars to that for gas tolls, travel time, time off work. And we also were able to look at if we were able to decrease the readmission rate by about half, what did that look like? So what was the cost per day of readmission to the NICU? And then we were able to kind of, you know, conservatively estimate the amount of money that was saved by averted readmissions. And so the project saved over $1 million in averted readmissions alone. We've published this work. This is one of our publications. We just had the 5-year publication was accepted, so it should be in press shortly. We also, as part of making sure we were sharing this information outside of our own health system, we partnered with University of Miami and we provided simulation training on the baby steps calls so that we could teach undergraduate nursing students what this looked like. What are the things you need to address? So that when we have our nurses going out into the workforce, they're actually prepared to provide this kind of care via telehealth. We also published a book chapter on the work. So if you're interested in learning more, there are lots of different resources. Again, it's been widely picked up and covered. And I think it is because it's such a universal experience. Having a baby in the NICU, having a loved one with a baby in the NICU, maybe having been a NICU baby yourself. So in the future, some things we're going to be working on is mental health screening and intervention for the moms in the program. What we're hearing time and time again is this is a huge concern once our babies go home. So we already know that NICU moms are at increased risk for anxiety and depression, but it has not been well studied what happens after the baby's discharged from the NICU. And so what we hypothesize is that there are some unique stressors there. And so for a lot of our families, that discharge happens after that 6 or 8 week follow-up with the OB/GYN would occur. And where we are in South Florida, there's very limited mental health support for moms. A lot of places won't even do the screening because if they screen, they then have to intervene and they don't want to assume that risk, which is something in all of South Florida that is a challenge. So we've written for a few grants to hopefully get funding to address that as part of the Baby Steps program. So putting in a validated tool to screen and then refer and connect with resources. And then, you know, really just thinking about how can we innovate to screen ahead of time to know which of these infants and families may need extra support. So that's where we're hoping to go. And we are hoping this is in one health system now. But the next goal is really to scale and spread this to other health systems. All right, so I see we have about 20 minutes left. So I'm going to talk a little bit about another clinically based program, innovation called Innovating for Impact. And this program, again, kind of grew from this idea that in that transition space, we have a lot of work that we can do to improve the outcomes for our families and our patients. And it's kind of this like hot potato area, right? Because we have our inpatient world and we have our outpatient world. And during that transition, we have a lot of challenges that can occur. So for this work, I partnered with our PAC team, which is our Pediatric Advanced Care team. And they provide care for our patients that need palliative and end-of-life care. And as you can imagine, in a children's hospital, we do have, you know, unfortunately, we have a lot of patients who need this sort of care. So every year in the US, about 50,000 children die from complex medical conditions. But what we find is there's actually, you know, almost 4 times as many that really could benefit from palliative care, about 200,000 children. And one of the challenges is that for most children, they can only access those palliative or end-of-life care services when they are physically in the hospital. But for a lot of patients and families, that doesn't align with what they really want for their child at end of life. A lot of them want to receive services in their home. They want their child to be able to pass in their home setting. And it's this tug of war between, do we stay in the hospital because that's where we can access services, or do we go home and try to piece it together in the community setting because that's where we're most comfortable and that's where we feel most at peace. In South Florida, again, where we are located, there are a lot of challenges to trying to go out of the inpatient setting and receive services in the community. We don't have a strong skilled pediatric nursing system. If there is pediatric nursing available, they are almost definitely not trained in palliative and end-of-life care. And there's also surprisingly a huge language barrier as well. And so these were all kind of issues that we were aware of. And as a interprofessional team, so it was, nurses, nurse practitioners, physicians, nurse navigators, social work, pastoral care. We tried to address these issues. So we were able to get some funding from the Hillman Foundation to develop an innovative program called Innovating for Impact, where we really, from the ground up, build a program to identify patients and families who would, who would have value from receiving these services. And then we piloted the program to provide, once again, kind of this transition of care, telehealth support to be able to support the families and patients in the hospital, in the home care setting instead of in the hospital. And so we wanted to look at some things like, what did readmissions look like? Were we providing the service, but the patients were coming back frequently anyway? Did it increase those parents' feelings of self-efficacy? What did family burden look like? Was this incredibly burdensome for families, or did this align with their needs? And then ultimately, and really importantly, we wanted to see if we could have death align with the family wishes. And so that was a really kind of driving goal for us, is kind of hearing that voice of the patient and the family and being able to address it. So this was some pilot work to really look at kind of the feasibility of doing this. How do you stand it up? What does it look like? How can you support it? So I talked about some of these things already. We had this interprofessional team. This universe of patients is well known to the PAC team. They work with them very closely. And so they were able to really assess which families were a good fit for this and which families could really benefit from this prior to going home. And so they were able to build that kind of therapeutic relationship before discharge and then continue it after discharge. The language concordance piece was huge for us. We wanted to make sure we eliminated that as a barrier. We used telehealth as our connection so that we could visualize the patient. We could still have that face-to-face, and we tried not to have the patient come back unless it was necessary. And then unlike the Baby Steps program, where the services are provided free of cost because it was grant funded, we knew that the grant funding would not be able to sustain this program for long. So we did build it so that it could be self-sustaining through billing. We recently published this work. We were able to do another thing popping up here. We were able to do a 1-year retrospective review of the program and some of the outcomes. So we had 27 patients that we provided care to in the first year of the program. As you can see, we had a very diverse patient population. Neurologic and oncologic process and disorders were our leading diagnoses, which not surprising given our pediatric population. And again, the language and the insurance source aligned with our hospital. What we found was, partially we wanted to know, what did these families really want? What were they looking for in these services? And you can see here on the left that a lot of what they wanted was just that longitudinal support. They wanted to, be able to have someone to check in with, someone to follow up with on the plan of care. There was a lot of focus on symptom management, as you can imagine. They didn't want their children to be in pain. If there were issues occurring, they wanted to be able to work with that NP or that PA or MD to be able to address those issues. And, they were also used for things like end of life discussions, like when is it time to transition and what does that look like? So, because this is such kind of a diverse patient population, we did not set the program up to be able to evaluate outcomes compared to baseline. But what we looked at was, did they use the emergency care, urgent care or ED during the time that they were in the program, and then were they readmitted? And what we found was the majority of our patients, 74%, were not readmitted, which was very interesting to us because these are very complex patients. And that was actually a departure from what we saw at baseline. We also saw the majority of our patients did not need to use the urgent care or the ED because they were able to access services through this program. So again, decreasing that utilization, decreasing that burden on our system and that burden on families. So we're continuing to kind of look at the outcomes of this, but again, just kind of thinking through how all of those different clinical research and family pieces came together to make this a possibility. So as we wrap up, I just wanted to kind of take a minute or two just to offer a little bit of insight, maybe. If you are kind of in the middle of your studies currently, if you are thinking about like, how do I do this work myself? So one of the things that I think is really important is the recognition that your path is unique. And so what I mean by that is you are going to bring your own clinical experience, your own life experience, your own view and lens on the world to your innovation. And so as you're thinking about, maybe you're at the bedside and you're thinking about how to improve things, that's okay if your perspective on it is a little bit different, because remember, you have come on a different path. So embrace that. It's a great thing. If we all thought the same way, it would be really boring and we wouldn't get anything done. Another thought is, it's hard to be what you can't see. And this is a Marian Wright Edelman quote. And for me, what I mean by this is if you are, a nurse and you're thinking differently, you're thinking innovatively, you're seeing these gaps, you're thinking of like cool ways you can address these issues, you may not see anyone else like you doing that work. And that can be really challenging. But just know that, there are many people out there who are just like you, who are kind of seeing the issues and trying to address them in these unique ways. And if you don't see anyone like you doing this work, then you should be the role model for others, right? You should be the role model for other students, for other clinicians, so that people can see this work being done. And then thinking about how you leverage your strengths. Again, something that you might see as a really challenging period in your life, something that was really difficult for you, that may actually be a strength as you think innovatively about improving care. So if, say you went through a period of PPA, postpartum anxiety with when you had your own children, you can empathize with moms who are now encountering that and the challenges and the frustrations. So anything that is, your unique experience, you can leverage as a strength. Some references in case you guys are interested. These are just some pictures of my team. So my clinical team, my leadership team. I have the opportunity to work with really great clinical nurses across the organization. I feel privileged to be in an organization that encourages innovation and recognizes the importance of research. And so I just wanted to give a shout out because as you can see, it takes a lot of people to do this work. When you're doing clinical implementation work, it's labor intensive. So just wanted to shout out. And then, if you're interested in learning more, my contact information is there. I would be happy to chat with anyone. Again, when I was going through my PhD, I didn't even know really about the role of a clinically based nurse scientist until my last year. And so if that's a role that resonates with you or you're interested in learning more or any part of it, I'm happy to chat. All right, thank you. I'm going to stop sharing.
Thanks so much, Danielle. That was great. It's always exciting to see work that's being done that is practical and can be applied and actually impact patient care in real time versus what we typically see, which is somebody looks at something, it gets into a journal, and then it
Yeah.
takes, an exorbitant
17
time.
years.
Yeah, exactly.
Yeah.
An exorbitant amount of time in order for it to actually get out and into practice and get some legs.
Yeah.
So I think it's fantastic to see that
Yeah.
sort of practice in action. Does anybody have any questions before we go? Okay. All right.
All right.
Quiet group today, but I really appreciate it.
Of
I really
course.
appreciate it. Great job. I
Well,
think
thank you.
I think I appreciated it too. My son had a critical illness when he was quite young and was hospitalized for a long period
Yeah.
of time. And then even bringing him home, you know what I mean? After they were like,
Yeah.
he's fine. I'm like, are you sure he's fine?
Yeah.
You know what I mean? Like there were a lot of questions, a lot of late night calls, and
Yeah.
lots of running back and forth to the ER for things that probably didn't need to be run back and forth for because you're so hyper vigilant over what's happening.
Yeah. I mean, and even I will say, like, as a pediatric nurse practitioner, I cared for newborn babies. I, provided that clinical transition to care support. And when I had my own daughter, I was scared, right? And she was
Yeah.
a normal pregnancy, uncomplicated delivery. And I texted my PNP friends, like, she has this little rash, like, is it okay? And I find it really interesting because I've talked to many different clinicians now. I
Mhm.
even worked with an MD who it was her, I think her second or her third baby, and she was breastfeeding, and she would bring her baby in every day to weigh because she was just herself so like nervous
Mhm.
about it. And I think about that a lot. Like if we have clinical education experience training and we feel that nervous, how does an average parent navigate that space? And by average, I mean a non-clinical parent,
Mhm.
or a parent who they're getting these instructions, but they maybe don't have the health literacy, or they don't have the literacy, like actual literacy.
Right.
And so, I think about that a lot, and I think that's been a big kind of driving force behind a lot of the work that I've done. So, yeah,
Yeah. Yeah. Well, it's great work.
thank
So
you.
yeah, good for that.
All
All
right,
right. It looks like we've,
peace out.
yeah, everyone's gone. So it was really nice to meet you. Hopefully I'll see you again. And
Yeah,
you're welcome,
absolutely.
Amber. It was great to meet you, Joe. We'll see you next time.
All right, bye guys.
Bye.